addictions. For years, the war on drugs focused on the crime of illegal drug sales and street violence in America's cities. But in recent years, our attention has turned to how to provide medical treatment for those dealing with drug addiction, and particularly those impacted by the opioid crisis and beyond. Thinkers on the center right have approached these issues from a variety of areas: public health, law enforcement, the economy, and more. But what truly works, and where are we at now with these issues? Joining me here today is Young Voices spokesperson Sofia Hamilton, who's worked extensively on healthcare policy, and Young Voices contributor Layal Bou Harfouch, a drug policy analyst focused on harm reduction and addiction treatment. Sofia, Layal, thank you so much for joining me today on this conversation about such a critical issue.
Thank you for having us here today, Sam.
Yeah, thanks for having us.
So I wanted to start with getting an understanding of how both of you think the government should, particularly on the federal level, should be handling its role in dealing with drug addiction and treatment. Sofia, let's start with you.
Yeah, so I think first, the most important thing to put out here is the government is not our doctor, and they need to get out of the way of treatment. Everyone's bodies work differently, and the government has this top-down approach, one-size-fits-all look at medicine, and they're stopping a lot of good treatments from getting to the market, and they're making it really difficult for patients to get treatment from doctors and their healthcare providers. So the government needs to get out of their lane, stay out of medicine, and let doctors be doctors and patients be patients.
Yeah, do you agree?
I would agree. Yeah, I would definitely agree with that. And also too, they set, on the federal level at least, set a really important precedent for the creative freedom and expression that basically the states and the local, levels thereby have. And so when you think about, okay, how can I set up, they should be thinking about how can I set up the states for success and the localities for success. And so that looks like, to me, getting out of the way and removing a lot of that bureaucratic red tape that's really unnecessary and blocking a lot of innovation and evidence-based medicine to work in its best form. So
now, I have a little bit of suspicion, but I want you to answer clearly. Is the current administration thinking this way?
Absolutely not. It's kind of interesting. Recently there was that the Great American Recovery Initiative that just came out, their recent executive order, and in that they're claiming that they're taking a public health approach to the drug crisis, and I don't think they could be further from the mark on that. It's when you're talking about a public health approach, that doesn't mean border control and bombing boats in the name of the drug war, and so they take a largely supply side enforcement level approach, which has shown to be widely ineffective. And if it was effective, we would be done with the drug war by now. So no, I think they're completely misaligned.
Sofia, do you agree with that?
Yeah, I fully agree. I had just seen the Great American Recovery Initiative executive order that came out at the end of January, and it's a lot of flowery language where it sounds nice, but how is it going to be implemented? And there's really no steps to implementation. I think with a lot of this administrative executive orders, and honestly executive orders in general, there's not a lot of information there. So I honestly have no clue how this executive order is going to be implemented. But from reading it, it doesn't seem like it's going to create a real public health approach, as Layal is saying. There's no real evidence-based treatments here. It's just, we're going to get these people healthy. We're going to get them to beat their addictions. And that's not how addiction treatment works in reality. And so I think it's well-intended. I think it's great that the administration is focusing on drug addiction and these perils that so many Americans are facing, but they need to look to the actual doctors instead of this anti-use purity mindset that they seem to be focusing on here.
Yeah, so let's dig into that actually a little bit. From what I saw, it sounded very great. Secretary Kennedy specifically said he's committing to investing in connecting addicts with faith-based community, 12-step programs, early intervention, and long-term recovery. And I think it was just announced this week that they're trying to make a $100 million investment in pilot programs focused specifically on homelessness and substance abuse in some of the cities most affected by this. Can you explain a little bit why that's not the approach you would take to this, or why a lot of it may sound nice, but is unlikely to see the actual public administration that would get the outcomes? I think ultimately the administration, all of us, are pretty aligned on what ultimately you want to see, but maybe aren't really connecting the dots there. We can start with Sofia.
Yeah, I think sometimes 12-step programs can work for some people. Faith-based organizations can work for some people. And it's great to have access to those resources if they work for you. But addiction is not a one-size-fits-all issue. And so if these programs aren't compulsory, I'm glad that more people will have access to them. But that's not what we need. We have so many resources when it comes to 12-step programs, AA, NA, and so on. We need these evidence-based medication-assisted treatments, and the government is in the way. The government is killing Americans because they are blocking access to these treatments, and the executive order makes no mention of that. And I'm sure Layal can add to that because this is really where she specializes.
Yeah, no, I would completely agree. I think, faith-based programs, they're great. They have evidence behind them as well, but they are not the only tool in our broad toolkit that we should have. When we're talking about different types of patients, different lifestyles, different ways people have even gotten to the point where they are when it comes to any substance use disorders, it takes different things to address those issues. And so with that, I think, no issue with the faith-based programs, but, if you can't claim a public health approach and completely disregard harm reduction and all of the tools we have at our disposal. I mean, we have naloxone saturation, which is the drug to reverse overdoses. That has shown to save so many lives for people who 12-step doesn't work, right? And we need to be prepared to address their overdoses. There's syringe exchange, which helps prevent communicable disease. So the Hep C and HIV that comes from sharing needles. So syringe exchange provides clean needles for people. Overdose prevention centers, which gets drug use off of the streets and into a kind of like a place where they can use pre-obtained drugs and have medical staff on standby to address their overdose event if it were to happen, and also connect them to other social services. There's other ways that are a bit more pragmatic than just plainly offering a 12-step as your only option here, for recovery. I mean, and they're backed by decades of evidence, but we're amply going against that. And from a lot of what I've seen from, Secretary Kennedy is because he himself, went through 12-step and, had a successful recovery that way, which is great. Kudos to him on that. But that's not the case for the rest of the American people. And so it's really important to think about this as, a doctor doesn't come to a patient with only one tool to be able to use, right? Like a doctor comes with the wide variety, and the patient should have the option to choose from that wide variety. And so, that's why it's not as strong as it could be.
It's very interesting. Sophia, I want to pivot away for a second and ask you a little bit about something you've worked on pretty extensively, which is opioids, and particularly the opioid crisis that has been affecting our country for pretty long now. It's been obviously a huge priority of this administration. It's very connected to their electoral coalition. How should we be thinking about the opioid crisis at this point, and what are some of the policies that you've been working on to help address those issues?
Yeah, so I think this current administration is still looking at it from a drug war perspective. And we know the drug war has failed. We've been in that since what, like the 70s, the 60s. It has not made Americans safer. It's not getting more people off of drugs. It's gotten more people onto drugs. We now have more dangerous drugs than we did when the drug war started decades ago. And that's because prohibition doesn't work. Prohibition bolsters the illicit market and gets us more dangerous drugs, because when there's more enforcement, you need smaller drugs, and those smaller drugs are more potent. And that's why now when they started attacking fentanyl, now we're seeing the rise in xylazines. And so I think they need to take a step back from the drug war. We've realized it doesn't work. We need to try these real approaches to getting people off of drugs and dealing with their addictions. And so instead of treating it like a criminal justice issue, you have to treat it like a medical issue, like it is. And I will give RFK kudos for this. I did like when he was discussing the streets program that we were just talking about. He noted that addiction is not a moral issue and that we should treat it like a chronic disease, like it is. And I love that framing, but that's not how the policy is working. They're still going after fentanyl like it's the drug war of the 70s. President Trump had his executive order where he called fentanyl a weapon of mass destruction. That is not going to stop people from using fentanyl. We also use fentanyl in medical settings all of the time. That's typically what you're using for pain or to put people asleep in the hospitals. And so I think we need to look at it like the medical issue that it is, and also have those wraparound services, because we know that there's a huge correlation with drug abuse, with mental health issues, with homelessness. And so when we have those services like Layal was talking about, the needle exchange programs and the drug use centers, you can have those intervention points where you can get those wraparound services and you can get people into a safer location and also get them off the streets and make sure our communities are safer and you're no longer walking into needles or people using drugs, and you have just a safer overall community for all people, including those who use drugs and have addiction.
Layal, are we missing anything here?
Oh no, I don't think so at all. I mean, like Sophia was saying, like the wraparound services are key here. And when we're talking about this kind of war on drugs, it's war on the substance that doesn't make sense, right? Like, as Sophia was saying, fentanyl is used quite frequently in the medical setting, but the problem is not the substance. And the more we focus on the substance, the more dangerous substances come out. I mean, the substances become easier to traffic and cheaper and smaller. Synthetic opioids are a real problem here. And the more that we criminalize the substance and stop, and focus on one method of treatment that, only addresses a certain part of this population, the worse that this is going to get. Policy has no way of keeping up with the speed of the new synthetic opioids and the drugs that are coming out as a result of criminalization. And so, we need to take a step back and think about how we're addressing this overall.
So, Sophia, you touched on it a little bit, but I'm curious, in order to get to this better spot when it comes to providing those different treatments, having a lot more options on the table that can ultimately address this addiction crisis, what are some of the regulatory barriers that are standing in the way right now? What is the policy that would get us to that point?
There needs to be a lot of reform. So there's three big agencies that I have a problem with. So I'm the FDA's biggest hater, also the DEA's, and also Sam says. So the FDA regulates drugs that come to market. For drugs that are coming to market, it takes typically about 10 years and about $3 billion to get a drug to market. And so that's starting from when scientists start doing research to it actually being sold to patients. A lot of that time and a lot of that money is because of the FDA's backwards approval process. And so it takes a lot of time to develop a drug and go through the testing, but the FDA requires so many different approvals and so much different testing to ensure that it's completely safe and no one's going to have an adverse reaction, when we know that people's bodies react differently to different drugs. And so they keep these really cool, really good novel treatments off of the market out of this safetyism approach. And so you can see this when you look at other countries' markets that are very similar to ours. I know in Europe, they have a lot better cold medicines than we do. And so France has a better cough medicine than we do because the FDA won't approve it, when we know when France's version of the FDA is just fine. You see the same thing in South Korea. They have better beauty products and cosmetics because that's also in FDA's purview. And you can go on. So the FDA keeps a lot of good drugs that could be on the market. And so like looking at alternatives to opioids. So for pain patients that get addicted to the opioids that they're prescribed for their pain, other non-addictive alternatives to opioids that the FDA is keeping off of the market because of the safetyism approach, when really what they have on the market is hurting patients. Then you can look at the DEA. They're the ones who schedule drugs. So they're the ones who put cannabis as Schedule 1, which is the most restrictive scheduling. That means that the government at least thinks that there's no scientific or medical use for that drug, and it has a huge possibility for abuse. They've been very bad at scheduling drugs, and they make it much more difficult to get access to drugs and treatment, and to also study drugs. And we've seen that with cannabis and also with opioids. And then we can look at SAMHSA. So that's the Substance Abuse and Mental Health Services Administration. They're the ones who make all of the regulations around access to treatment. So one of my focuses has been on access to treatment for methadone. So methadone is one avenue you can use to treat opioid use disorder. And there's a lot of different medications. There's also buprenorphine. There's a couple others. But people have different reactions to the different medications. And for some people, methadone is the best medication that they can get. But SAMHSA puts so many different restrictions on getting access to methadone. They make you can't get it from a normal doctor's office. You definitely can't get it from a pharmacy. You have to go to a clinic, and you have to go there daily to get your daily dose of the medication so you can get off of opioids, because they don't trust these patients. They think that these patients are going to be using methadone recreationally, which just doesn't happen. It's not a fun drug to use recreationally anyways. And so they make all of these nonsensical regulations that make it so difficult to get treatments and to get new treatments onto the market. And the people who are getting punished are the patients. And honestly, the federal government is paying even more money for the treatment and the housing of these people in prisons because they want to criminalize the use of drugs. That just everyone in this situation is facing these negative consequences, when if we just allowed these proven treatments to come to market, everyone would be in a better place. So I'm sorry for my rant there, but if you talk about the FDA with me, I'm just going to have to go off.
And
Layal, I'm curious. You've covered a lot of these issues on the ground, particularly in some of our major cities like my own Philadelphia. What are some of the gaps to providing these kind of opioid treatments, not just in terms of the regulatory barriers, but in the actual implementation and administration in the communities most affected by them, the people that need them most?
Yeah, sure. Yeah, I mean, there's a lot. Let's start with even methadone that Sofia was talking about. I mean, in order to even take methadone, you have to travel to a clinic, like an OTP is what they call them. And so that presents a lot of barriers in itself, right? To have a supervised dose there because, especially for rural communities, people are traveling up to 45 minutes to 2 hours, even I've seen, to go to their methadone clinic and back for their dosing. And, that medication is meant to stabilize lives, is meant to stabilize people, to curb cravings. And so it needs to be offered consistently. Adherence to medication is a huge part of, what makes it effective. And so imagine you have this medication that's intended to stabilize your life so you can hold down a job and you can live your life with your family and, not be distracted by everything that comes with addiction. And you have to choose between the job and the actual, medication that's going to help you, stabilize your life, because no job is going to let you go 2 hours to your clinic and back. I mean, what 9 to 5 is going to allow you to take that break for your meds? So functionally, on paper, it looks great, right? Oh yeah, we're just going to have them be supervised with their dose and, and everything will work fine. But in practice, it is falling short, quite plainly. Like it's a great medication, and only 35% of people are able to even access a medication because of barriers like that, right? Which is crazy to me. I mean, it's it's misaligned intention with implementation there. And so people have innovated a bit to try to get people access to different types of services. Some I haven't read too much about medication being distributed on things like mobile units, like what I wrote about in Philadelphia, but that can get people connected to different aspects of care. There's syringe exchange is usually offered on those mobile units, and different health checkups, infectious disease checks, things like that. And so people have innovated to get people connected beyond those medication assisted treatments. But, plainly what needs to happen for the access issue in particular is we need to address this OTP model. It's absolutely archaic. And also there's a lot of oversight on the prescription of things like methadone and buprenorphine. And so buprenorphine is the other medication. And then there's also naltrexone, but that's a bit, that's not as big of a player as methadone and bupe. Methadone and bupe are pretty much the two main ones. And so there's a lot of oversight to that, which can make providers less willing to prescribe because they are, under such oversight from entities like the DEA. And then, beyond that, there's also a big training gap, to be able to prescribe medications. Medical providers need to go through an addiction fellowship. And, they're not taught to manage addiction in medical school, which is an interesting thing. It's quite interesting. You have to go through that extra level of training to even know how to manage addiction properly. And even when you go through that addiction training, right, like there's also this kind of context specific consideration also when you go into practice. Like right now we're in a heavy fentanyl era, right? So the way that you microdose people on and off of methadone and bupe has to be adjusted to, the context of what drugs they're using. And so fentanyl is incredibly more potent than heroin, right? And now with xylazine is getting crazy. The nitazines too are a big thing that are popping up, which are even more powerful than fentanyl. And so that's going to call for more dosage of the medication needed. But if you're not trained in that, you're not going to know, right, to do that. So there's a lot of just kind of these like nuances of like, we are just not addressing this from every kind of small angle that we have here.
Gotcha. I think a lot of what you touched on falls under the bucket of what you describe as and focus on of harm reduction. Over the past couple of years, that word has become very politically charged, and it's been used by a wide range of people from very progressive members of the far left to a lot of libertarians. I'm curious, what do you mean when you say harm reduction, and how do you approach these issues, maybe specifically from your certain ideological outlook and distinguish it in times where it's taken on a whole nother meaning a lot of times politically?
Yeah, that's a great question. Yeah, it has kind of blown up to be something that, people aren't even allowed to say anymore, which is nuts to me. But, the harm reduction to me and how I take a look at it is that it's more of a frame of mind, right, around reducing harm in any aspect that you can. When we're talking about, especially when we're talking about public policy, we tend to be super siloed in our approaches, right? So like, it's kind of like a similar idea of if you go to like a cardiologist, they're going to tell you there's something wrong with your heart. And if you go to a dermatologist, they're going to say, no, it's a skin problem. Like we tend to be super siloed, and there's not a huge like continuum of people talking to each other in that sense. And so harm reduction is, kind of a holistic view of different issues with the focus of reducing harm. Harm reduction shows up in our lives every single day. When we're talking about even you get up and you brush your teeth in the morning. Yeah, you're reducing harm. You go in your car and you put your seatbelt on. You're reducing the potential of any harm there. So it doesn't just apply to drugs. But it does, and it's super interdisciplinary in its nature. And so when we're talking about drugs, a lot of things have come up that that cross discipline, so to speak. There's a criminal justice aspect to this with reentry. A lot of people start medication for opioid use in incarceration, but then lose that continuity when they leave because there's not that continuum. Like criminal justice doesn't talk to healthcare, or people are hesitant to go get healthcare, especially women who are pregnant, who are addicted to drugs, hesitate to go get healthcare because there's a co-opting of healthcare and also criminal justice there, because they'll get reported and their kids will get taken away. And so there is so much overlap in how this plays out in our day-to-day, but harm reduction is looking at the big picture of where people are in their life and pragmatically addressing those harms in a way that's productive. And so when we look at it, we're not taking a siloed approach. We're not saying, okay, we're reducing harm here and not looking at the harm we're inflicting here in this other space.
Sophia, I'm curious how, in terms of the regulatory system of healthcare, how do you think about harm reduction?
Yeah, I mean, I think Layal's got it. It's funny to me because there's so many different medications outside of drug policy that are harm reduction, which Layal was saying. Like, you look at GLP-1s now, Ozempic, that is a harm reduction tool. That's it's so interesting to me because if you look back 10 years ago and how we talked about obesity, that was a moral issue. Those people were gluttonous. And now we're looking at it as it's a healthcare issue. And we're giving these people the medication. And so they don't have worse heart problems. They don't have all these other healthcare issues that could come up with obesity. And we're stopping it in its tracks. If we had that same approach to the regulation around methadone, that would be amazing. I can't imagine all of the good that would have for individuals that are struggling with drug addiction if we just treated it like the medical issue that it is. And I know harm reduction has become such a triggering word for some people, but it really is just medicine at its core.
I think to me, the harm reduction it sounds really good in theory from all these approaches, but I think one of the things that's caused a lot of hesitation, particularly for those in some of these very progressive cities that have tested out what they've described as particularly harm reduction, has been the public safety impact. We all know that drug addiction is not just a health issue, but it can come with a lot of spillover effects, obviously, in crime, in homelessness, and civil disorder. How do we go about balancing public safety concerns about, kids finding leftover needles on the subway, or people camping out in those subway stations, problems with the spillover effects of, violent crime being caused by drug cartels, instances where deals have gone wrong and led into deaths? How do you include both of those concerns when approaching these issues? We can start with Layal.
Yeah, sure. That's a really great question. I mean, in a lot of these instances, it's often the harm reduction approach that gets cut. And here I'm going to paint the picture so that makes a bit more sense. Like recently in Detroit, we had a concern where people were pooping in people's lawns. Right? Like, people who are using drugs, people who live on the street were pooping in people's lawns, and people didn't like it. Right. And it's like, they thought, it's the drugs, right? Like, it's these mobile units that are taking the people to the suburbs where there's, opportunity to do that. But then taking another look at the situation, there's no public bathrooms in the area. And so instead of addressing the public bathroom issue, they tried to cut the mobile syringe exchange van. So, there's this kind of like really quick move to cut people's the actual intervention, like the mobile unit, like same thing when in Kensington, where people were complaining about the litter, right? The syringes that were around the areas where the van was. Instead of saying, hey, maybe we need to hire more people to address kind of the environmental concerns, right? They want to cut where the van can go. And, that's kind of backwards logistically to me, right? Like, and ultimately when you implement these changes, the research and the evidence behind, rising crime rates around like things like overdose prevention centers where people can go and use their drugs. There's no evidence on increased crime around in the area. It's just kind of like, maybe the one or two people that venture outside of the center, and are slumped over like on a corner, right? And people are bothered by that. In any intervention, there's going to be some bad actors or some people that don't follow kind of like the majority protocol. But, the instinct shouldn't be to remove the intervention that is helping the 80% of people or 90% of people that are using it, just because of the 10% of people that have, diverted away or made some type of rash move that harmed another person. And so getting to your point about balancing that approach, that's where we balance it, is that if there's, irreversible harm that can't be addressed in any other way, then obviously there needs to be law enforcement involved in something like that. And so I don't think there's not a role at all for kind of like enforcement in any way. I mean, obviously, if there's potential for for a lot of things when it comes to drug use, but we just can't be taking away things so quickly because of a few bad actors. And so I think the balanced approach there is to really take a look at the problem, because I know, especially in policy, I feel like there's like a really it's like we want these short-term solutions. We want the Band-Aid that fixes everything and is a good PR headline and is like look at us, we did something about this. But let's not do something about it without the evidence that this is actually going to work. So that's my spiel on that.
Sophia, anything to add?
Yeah, I mean, I think a lot of what you were describing, Sam, are just consequences of the drug war itself. Like drug deals gone bad. Why are those people having drug deals in back alleys anyways? Because those drugs are illegal. If they were legalized and regulated, they wouldn't have to be in those sketchy situations. There wouldn't be violence there. And so I do think a lot of people like to point fingers at harm reduction services, but that's how we get the needles off of the street. And a lot of them have to work in the shadows. And if they were allowed through regulations and they weren't constantly being policed by the federal and state governments, then they could actually work as intended, and they wouldn't be trying to get more employees to pick up more of the needles. They would have the services that they would need to really address the issues. So I think people like to blame the problems of the drug war on harm reduction because it's very politically convenient. But that's actually one of the solutions that we're seeing is through these harm reduction services to the problem that the government created. So again, if the government just gets out of the way, we'll all be better for it.
Yeah.
Now,
reemphasize that, like the government getting out of the way. I mean, like there's so much gray area that's not getting covered by whatever they're prescribing right now, which harm reduction fills. Harm reduction bridges the gap because a lot of people, especially those who are addicted to drugs, are not engaged with traditional healthcare systems. And so who helps? It's those community-based organizations that are, offer harm reduction services that get them at least, in good health and not spreading communicable disease and, not dying for no reason, so there is that bridge that needs to be filled, and harm reduction shouldn't be the thing cut because that bridge is an important one to have.
Now, we've covered a lot about government programs, different prescription drugs that can be used for treatment, but we haven't touched on some of these natural remedies, some of these drugs that are currently illegal on the market, but have ultimately been proven to offer a lot of benefits to, whether that be quitting opioids, quitting other drugs, or simply for other medicinal and recreational uses. We can start with Sophia. I'm curious, where are we at with things like the legalization of marijuana, some of these other opioid alternatives that have been studied? is there not enough research on them? Or are we still really criminalizing them? Has there been any meaningful shift? There's been a lot of talk, I think, about weed for the past decade, but outside of some state level laws, not a lot of push to truly deregulate it. But you're the expert for sure.
Yeah, so when it comes to weed, when it was at a Schedule 1 drug, that made it incredibly difficult, if not impossible, to get studies on how effective marijuana use can be and like how other medical benefits it can have. So I think moving it down to Schedule 3 is a good first step. I would like to see it just recreationally legal in the same way that alcohol is. I think that's the most sensible approach there. But at least when it's at Schedule 3, more studies can be done. But that's great. I think one really interesting substance that we've been seeing a rise in popularity is kratom. So that's similar in like the natural sense that marijuana is. It comes from a tree leaf in Southeast Asia. It's been popular there for decades, probably even longer, and it's been gaining popularity in the United States. And that's something that users of opioids have been just organically using to help with their cravings and to get off of opioids. And so that's been something that's been really interesting to see users finding these solutions that the government isn't like creating for them. So I love that ingenuity there. But per usual, the government's coming in the way. They're trying to ban kratom now because they see people using it. And I think there's some issues with the kratom market. So until now, it's been pretty much unregulated. And typically I don't like regulations, but this has resulted in some pretty sketchy products. So I wrote an article about this because I ran into a problem with kratom where there's a lot of gas stations that are selling kratom products, but they're not really labeling it. And since there's no regulation, there's no requirement to label. There's no requirement to say how much kratom is in the product or to even say that there's kratom in it at all. So, and it's an intoxicating substance. I was in California. I was at a tea shop. I almost bought a drink that had kratom in it, and I was not looking to use kratom. Like, no judgment there. That's not what I wanted to do with my day. And I luckily saw that the drink had kratom in it because I work in drug policy. I knew what that was, and I was able to stop myself from purchasing it. And like, that's not a cool situation. So there's been a lot of people who have accidentally taken kratom, accidentally become, I don't know if it's not really an addictive substance, but like become dependent on it, let's say. And that's not cool. There needs to be proper labeling there, but the government's response per usual is to ban it. So we're seeing a lot of state pushes to ban kratom, and we're even seeing federal pushes to ban it. And that's not the solution. I think it's one, I think people should be able to use it recreationally if they want to. But I'm probably a little bit out there for some people, for the government at least. But if people are using this and finding benefits for it for opioid use disorder treatment, they should have access to it. And if they have access to a regulated product, then they can work with their doctors and actually like have a treatment plan that's more formalized. But people are going to kratom and getting it from sketchy gas stations where they don't know really what they're getting, because the government has failed them through these over regulations and pretty much the banning of these different treatments from the legal market. So I just think that's been a very interesting, like, kind of grassroots movement in the drug use space. But hopefully the government just never learns that the drug war doesn't work. Their first step is always prohibition, but we'll see what happens. But it's looking like they're going to ban kratom, unfortunately.
Sophia, maybe it'll work this time. Maybe it'll work.
maybe, Layal. They just need to try it one more time. It's different with this one.
What did they say? Like 5,000 times the charm? Like,
yeah, exactly.
Layal, I'm curious in terms of particularly, some of these on the ground approaches to harm reduction. Has any other kind of natural or herb kind of remedy been tried? Is there any states, I don't know, Oregon, Washington, that have been able to experiment with that being provided to people? Or there's been other programs, I don't know, particularly with veterans, particularly with the homeless, to provide some support for other issues in the mental health space and the PTSD space that you're familiar with?
Yeah, Reason does a lot of work. I have a lot of great colleagues that do amazing work on different psychedelics. So ibogaine and psilocybin and things like this. So they're like, basically ibogaine is a one-time treatment that can help like completely heal your withdrawal. Basically, like it doesn't allow for further withdrawal symptoms. So there's potential for it. Obviously, it's not a regulated formal substance here yet, but we're doing a lot of work to help kind of get more clinical trials up and running on that, because we're right now, with especially in the psychedelics world, right, we're outsourcing. People are going outside of the country to go and get these different types of treatments. And so I'm all for all these different types of potential treatments, and we should be doing the work to get them as a regulated, available option for everyone to be able to choose, right? Putting the power back in the patient's hands to choose what way they want to go. So yeah, there's a lot of cool things. Cannabis too obviously has a lot of potential for healing properties and other things like that as well. So there's a lot of excitement. Even GLP-1s have shown a really cool, like there's a lot of preliminary data around the fact that it's curbing opioid cravings. So there's really cool stuff. And
Wow.
when you let people innovate, when you let people innovate and bring forward these new treatments, we should again have all of these treatments in our toolkit and at our disposal, especially our healthcare providers who are addressing this head on. They should be able to have as many tools as possible to make sure that the experience and the healing experience and the patient provider relationship is truly patient centered and aligned with what the patient wants.
Both of you mentioned how a lot of those substances are not regulated, and that kind of is a barrier to them being able to be medically used, let alone recreationally used. But at the same time, we're advocating pretty harshly for deregulation of the space. How do you, in your mental models of all these policy issues, balance some level of basic regulation for this, ensuring something is safe, ensuring it's not being tampered with, it's properly labeled what people are actually buying so they can dosage it appropriately, with trying to cut up a lot of your other regulation? It seems like you're kind of, coming from both sides of the issue.
Yeah, there's like a kind of a realism to all of this, right? Obviously, ideally, we are not fans of, the government regulating a lot of things, but obviously there is a realism of like, if it's going to be applied in a medical context, that there needs to be some bare minimum form of like, what you're getting, at least, right? And basically the administration piece, or like the prescription piece, falls on the specialists and not big government. So like when you're talking about like how it's actually implemented, we're relying on the specialty of the people who are actually closest to the patient. And I think that's like the important distinguishing factor here, is like, what you're getting, and then two, the doctor can actually use it.
Yeah, 100% agree. Like I said at the beginning, the FDA is really bad at their job. And I just want them to do one core function, and that's to make sure that the drugs that we have on the market are the same thing. They have the same doses, that they're reliable, that they're safe, and to get all of the good drugs on the market and the bad ones off. And so I don't think that the government should have any place in saying what treatments people should get at what doses and what times and where and so on, like they do with so many different medications like methadone. That's what doctors are trained to do. They, like Layal said, they have to go through a separate program to get a separate certification, separate training to become addiction specialists. They're not even taught how to do that in normal medical school. So how is the government supposed to do this? How do they have the expertise to say at what dosage you should be getting your methadone, and at what time and where, and how many take-home doses you can get? That's over regulation. And so I'd love to see no FDA. That would be perfect world. That's not going to happen. That's not politically feasible. I see a lot of people also arguing for decriminalization. That is not the solution. I don't want there to be criminal punishments for drug use. So that's not my argument there. That's not where I'm saying decriminalization doesn't work. Decriminalization means there's no regulation of the drugs. So that's basically where we're at with kratom. And that's where you're seeing the illicit market and the sketchy products in the gas stations down the street. And so if you actually have regulation and you can have those consistent products, then you can work with your doctors. Because right now you can't go to a doctor and get them to write you a prescription for kratom or even a treatment plan from kratom that you get at your gas station, because they will get in trouble with the DEA. There's so many restrictions, and so many doctors just refuse to prescribe opioids now because of all of the DEA restrictions and how much of a threat there is for them getting in trouble. So I just think the overregulation here has just made it so much harder for patients to get good treatment. And if the government just did the core functions of their job well, which they're not even doing, we'd be better off for it. But I think that's too much to hope for, too much to ask.
On that front, you mentioned decriminalization. There's been a pretty big pushback this week against what has been the decriminalization of marijuana. First with a New York Times article, and then with a lot of big name accounts posting on X, particularly those in the conservative space, saying that what was sold was some level of essentially legalization, if not in name, essentially in action, and then subsequent regulation to ensure, people are not, smoking in public places, to make sure that these products are being regulated for, different safety product concerns, that they weren't being sold to kids, etc. Where are we at with the law around marijuana, and how can we address some of those concerns that are being raised, but not see this total pushback to going back to, I think, square one, which is complete regulation, complete illegalization, and really bad, harsh criminal penalties, particularly for a lot of communities that don't have the access to the protections that they need legally, that are already targeted pretty heavily by the justice system. But there's not, I think, a lot of voices pushing back on this issue right now.
Yeah, so this has been such a confusing area for policy. So we've seen so many states in the past couple of decades legalize cannabis, and that was in direct conflict with the federal law, which had it at Schedule 1. And so there was this really weird legal gray area, where then now people are on registries because they are a cannabis user, and it just puts consumers in a bad place. So there's also, while states have been legalizing, other states have been decriminalizing. And so Washington, D.C., where I live, is a great example of this. And I've written an article about it because I saw the problems firsthand. So they decriminalized cannabis use a couple years ago, within the past 10 years. And this is why it's not the solution that people think it is. Sure, it's great that you can't get in legal trouble. You can still get in legal trouble with the federal government, just not the locality there. But they're not creating a legal market for it. They have this really weird workaround system in DC where it's gifting. You can go to a dispensary, which is just a shop. There's some regulations around it. It was very poorly enforced in DC. And you can buy a product that's probably a little bit less sketchy than what you would get from a dealer on the street. But you don't actually buy the product. You're buying a t-shirt or a sticker or a bag of chips, and then you're gifted in exchange the cannabis product. So you're buying like a $40 bag of chips for some weed there. And that's just not a legal system. There's no regulation there. And that just resulted in a lot of counterfeit cannabis products, especially around like edibles. And this is a huge detriment to the city because they could be getting, I'm not a fan of this, but they could be getting a lot of tax revenue like Colorado's done. And so I think Colorado's had a good legalization system, but the decriminalization just has not worked. And now DC cracked down on the decrimmed market, and a lot of those shops don't exist anymore. And I think it was just a huge testament to what a failure decriminalization is. But from the outside, it sounds like a good idea. It sounds like you're just not going to have criminal punishments anymore, but you're not creating a legal market. And that's what we need if you want to have recreational drugs. If you want to have recreational cannabis, you need to have a legal way to buy a regulated product.
Layal, anything to add?
I really don't have too much to add there. You really hit on a lot of it, Sophia. I think it's like, again, the approach of trying to kind of almost like attack the substance instead of the implementation of the process of using the substance is kind of like it's kind of like a backwards mentality, as we've mentioned before. So the only way to know how to truly address it is to also just let things happen and then truly like see and collect data on what are the shortfalls there, so we can properly and have a targeted approach to regulation, not just throwing these regulations willy-nilly, you know what I mean? Because they, obviously, as we've seen with that approach, it doesn't work. And so just truly looking at what each community needs and having a more targeted harm reductive approach in that sense.
To wrap up, I wanted to ask both of you if you could share one aspect of drug policy that we haven't covered yet that you wish more people would talk about.
I wish more people.
Oh, no, you go first. You go first.
I wish more people would talk about like the external costs that the drug war has on people, more than people who are just also more than the people who are using. I mean, we've spent over $2.7 trillion in public, it's public dollars that we've spent on enforcement side, abstinence-centric approaches that have yet to get us out of this issue. And so I wish people would talk more about kind of like also the comparative costs and benefits to the drug war for everybody. I mean, when we talk about syringe exchange, right? When we're giving people clean needles, then we reduce the infectious disease that is present that you can also get, even if you're not using, right? Like you can also get those infectious diseases. So it's of interest for the public as well, right? The overdose prevention centers, I save so much money when it comes to emergency response and people using. Oh no, did we lose Sophia? But we save so much money in overdose prevention centers and, like the emergency response, the healthcare system use and overburden of the healthcare system by providing the bridge through the overdose prevention centers. We save so much with naloxone too. I mean, when we don't have to deploy emergency response to address an overdose event, that saves so much money. And so I wish we would talk more about, like the public gets impacted by these interventions too, not just the person who's using.
I think we might have lost Sophia before the end.
Yeah, we did, I think.
All right. Well, with that, unfortunately, we're going to have to wrap up a little early, missing her closing remarks. But it was really interesting to hear from both of you today about these critical issues. I think that there's a lot of different outlooks to be had in this space, and it's refreshing to hear. Oh, did we get you back?
Hey.
One thing you wish more people would talk about?
Oh no, now we
can't hear her now.
I'm just going to be quiet for a second because I can't hear anything. Sorry.
Okay. Do we get you back?
Okay, I'm so sorry. Can you hear me now?
Yeah.
Okay, great. So the one thing that I wish people would talk about, and we kind of touched on this earlier, is just that people who use drugs are humans. They're real people and they deserve to be treated like it. And so this isn't a moral flaw, even if you think that it is, even if it's against your moral compass, it's not something that you would do. That shouldn't matter. These people still deserve treatment. They still deserve to be treated like humans. And I wish that the law would represent that. And hopefully we'll get to a place where the government understands that as well.
Thank you. Well, thank you both for joining me today. I think that everybody learned a whole lot, and these were great perspectives shared. And thank you for everybody watching. That's all for today, folks.
Thank you.